When you're now talking about USSD codes, star something something hash, there is another one that you need to think about and you need to get on to today. Which one is that, Harry?
Star 147 hash.
Bas. Star 1. If you have to forget anything else, do not forget star 147 hash. Because you want health services, you need star 147 hash. Register into the new SHA. It's a social health authority.
It is SHA.
Social Health Authority.
Social Health Authority.
Very good. We'll be talking about shortly with the Principal Secretary for Medical Services in the Ministry of Health, Harry Kimtai. Good morning, PS.
Good morning and happy new month.
Yeah, but
You guys are talking of how the year is going, moving very fast.
Yeah.
it's moving
Huh?
very, very fast. I'm sure even for you, October last year, the President launches this universal health coverage.
Yes.
A year later, and we are now rolling it out.
Yes.
It's been a busy 1 year, hasn't
It
it?
is a very busy 1 year, but today is a D-Day. Of course, we are telling Kenyans there's going to be a change of how our healthcare system is going to be delivered. The word is delivered. Because it's not just going to hospital. You've just said that you want everything to be done within your fingertips.
Yep.
Even this one.
Yep.
You want to book your appointment for a doctor. Before you go, you book it. So that's how we could also bring it closer to you, closer home.
Where? Hey, you'll tell us more about it. Let me welcome you with the day's proverb, courtesy of our friend CT, who's been away. We said he'll be back next month. Next month has started.
Yes.
Okay, next month, the other one, another day next month. But when we say next month, it doesn't mean at the beginning of the month. It means some time within the month. So CT will be back this month. The proverbs for this week have been from the Gambia. Have you been to the Gambia, PS?
No, I've not been to Gambia.
Okay.
But some of those West African countries, yes, I've been there.
You've been to Senegal?
I've been to Senegal.
Ah,
I've been to Ivory Coast.
okay.
Yes.
Now you know that Gambia is like inside Senegal.
Inside Senegal, you're right.
So you've been in the hood.
Yeah.
Today's proverb, whoever comes last drinks muddy water. Whoever comes last drinks muddy water. What do you think the proverb is saying?
Basically, you should be the first one so that you drink the clean water. Yeah.
That's it.
That's it.
The early bird.
Catches the worm.
Bas. Safi, it's the 1st of October. There's a lot of confusion in this country. What exactly is happening today? When you say we are rolling out, we are starting, what are we starting?
We are starting or rolling out the new healthcare system that is able to be delivered with the new technology, that's ICT, as you've said, because this time you're saying that we want people to be registered so that when you go to a hospital, you're known. And you see, we started much early. We started with the community health promoters last year, September. The president launched the community health promoters. And what we did was basically equip the community health promoters with a phone with a system that's called the electronic community health information system, whereby when you're visited by the community health promoter in your household, they're able to interact with you, and we give them the app has what's called, you can test the blood sugar, you can know the pressure, the blood pressure, and that is sent to the next nearest hospital, which is called the PCN, the primary care network, because what we did is we clustered facilities within an area. So, and when you have, say, for example, high blood pressure, you are informed by the CHP that please visit your nearest health facility. So when you reach there, you find that your details are already captured there. So the health provider there will look at you and start taking care of your details, more details now. So we started at that community level where we started the household. And now we said we must now move to the next, where we say we must digitize our healthcare system. And it was really important that we do that. Initially, when you were the previous governments, Kibaki, Uhuru, tried the launch of UHC, Universal Healthcare Coverage. But there was a problem. The problem is we launched it using the same system, and we call it UHC. So That's why it failed, because nothing changed fundamentally. This time, we said we needed to have a legal framework, the strong foundation that will be able to deliver UHC. One of it is making sure that we digitize our healthcare system end to end. And that's why we have the Digital Health Act, because it is through the Digital Health Act that will help us then deliver. One, we needed data of our patient records. We've seen cases where you go to hospital, you are treated in hospital A, you're told to go for tests, you do all those tests, and then maybe another day you realize you are in Kakamega and you had done the test in Nairobi.
Yeah.
So all your data is in that facility, in that hospital. When you're in Kakamega, you go and start afresh. We are saying we want a patient journey. How do we sustain the patient journey? We must have the patient records, which is called the client registry, meaning that we have a big database or a system that is able to have the registries for the patient, a registry for the healthcare provider, a registry for the facilities, so that all these are able to integrate. You're able to see a patient when you're in Kakamega and see where the record of this patient, where was that patient, what was the treatment, what was the earlier treatment, and what is the current situation. So it helps the doctor using your history to really treat you well. Two, this facility that's treating you. And that is basically for the purpose of refund or claim. Because we have been having cases of fictitious claims. What kind of facility is this? All right, when you register a hospital, what kind of hospital is this? You must describe your services. We must know what services do you offer. So that we at the Social Health Authority, when you are processing your claims, we are able to know what are you offering. Is it commensurate? Is it what you do? So that there is no fictitious claims. That's why we have the facility register. We must know. The doctor who is treating you as well. Is this doctor licensed? Because we want a competent authority, which is the Kenya Medical and Dentist Practitioners Council, who are mandated to regulate the profession. So are you the one treating? So all these things have to be captured. How do you do this? It's only through digitization. So it is important to digitize. And that's why one of those laws that were enacted were the Digital Health Act. The other one was the Primary Health Care Act. Healthcare Act. Now, this one, we factored in the issue of the primary health care because we were shifting from curative now to preventive, promotive. We wanted to take that because it's better to prevent than to cure. So to shift that, we had to pass a law. And that's the Primary Healthcare Act. And therefore, it takes the people to the law facility. Eric, you know, a problem with our system or our healthcare system is we have forgotten this principle of referral. Because you wake up and you want to go to the top-notch hospital on small ailments. Yet you are supposed to go to your nearest healthcare facility. And that's why we categorize the healthcare systems facilities in terms of levels. What level is this? And what happens to that level? So that gradually you move on, depending with how the progress of your disease and the specialization or the requirements that you're supposed to get for you to be treated better. So all this is what we want to do, and that's why we had this act that you must and then go to your primary care network where you are mapped within that area. You wake up, you have got a headache, you're not feeling well, pains. You go to that primary health care. You walk there, all right? And then you come back. Maybe you're given painkillers, you're checked, simple tests are done, you go back home. But if it persists, then even then the records will start being captured. So by the time you reach our national referral hospital, all your history is known. So that act was put there. The other one, which is very key, is how do we finance our healthcare system? The financing model. We needed to look at it. Of course, we had the NHIF Act. And we realized the NHIF Act did not really help us a lot in terms of trying to come up with an equity. How do we distribute? How do we fund our healthcare? Those who are employed, the maximum you could pay was 1,700. So it was not equitable. If you do the costing there in terms of percentage contribution, you realize that even those who are low-income earners and they are paying their 500 based on their income, you can see they are paying more in terms of percentage. So we came up with our funding model through the Social Health Insurance Act that we have 2.75% as what you are required to contribute as your social insurance. Why this? People ask 2.75%. Yes, because we needed funding. And we needed national social health insurance where we say those who are healthy will have to contribute and pay for the ones who are sick. Those who are young will have to contribute and pay for those who are old, because as you age, definitely you're prone to...
You need more.
Yes, you need more care. And those who have more income should also contribute, so that by the percentage share, you contribute, all of you contribute that percentage share. So it's equal. Equity is what we are looking at.
Yeah.
So in that... we realized that we needed to have a pool, because this insurance, we pull the risk together. We all contribute and put it there. So once our pool is there, then what are the benefits that you need to get? So, and that's why we started giving the benefits. And as we are designing the benefit package, we looked at what is currently being offered, because you could not go below what the citizens are getting based on the insurance fund that we have. So he said that be the basis, and then looked at how then we need to increase this. That's why when you go inside the benefit packages, the dialysis, for example, now is different, and then issues like surgery we've increased. You'll find you can go up to $1 million depending on the kind of procedure. So that's where we started, and basically. So the key thing that's happening today then is what? When you go to hospital, we expect you now to have registered. That's the first thing, to have registered.
So registered to what?
Registered to Social Health Insurance Authority.
So is it registered to the Social Health Authority or to the Social Health Insurance?
You register for Social Health Insurance which is managed by the Social Health Authority. So the authority that is managing the registration is Social Health Authority.
P.S., can I take you a few steps back, please?
Yes.
The digitization of all of this makes sense, and I think it's clear that it's important to have a healthcare system where everybody's in the system, so that you don't have to go back and take history and things like that. That makes sense, and I would expect that any healthcare system in a country worth its salt would follow that kind of model. But you already had something like that in NHIF. So the question was that could you then have taken the database that you had on the NHIF, because if you'd go and clock in your information would be there as somebody who was a practicing user of NHIF. So would there have been an issue to basically move the database from NHIF as it was to SHIF, SHIF now, so that you then removed the element of people having to go and register again? And then what you do over time is that you add new members. Would that have been a possibility?
Yes, we thought of it, and we realized that we had the option of moving, which actually it has happened. I'll tell you, the Act requires that every Kenyan above the age of 18 registers. So we made that registration to be mandatory. You're supposed to register. Those who are in NHIF were the ones who are contributing either through your employer, when you're employed, or those who have chosen voluntarily, the ones who have said, we want to join the scheme. So their number was limited. We had, if you look at the data of NHIF, we had about 12 million NHIF registered members. All right, that was the data they have. So we wanted all Kenyans to register because of the primary health care fund. You see, the primary healthcare fund, which is funded by the Exchequer, everybody who is registered is entitled. That means if you go to a level 2, level 3, you should be treated and you go back home. because that has been funded by the Exchequer. You could not do that with NHIF data. Because we needed now data of everybody who has been registered.
Everybody.
Everybody. So, and that's why we are saying we want to take you to your primary health care network, and then you get your free care there, all right? And then progressively, if your disease becomes complicated, then you move to the level 4, which is basically your social health insurance, the SHIF now, all right? That's when it sets in.
So 1, 2, 3.
Another thing I want to
free.
add. Yes, 1, 2, 3 is
it's tax funded.
It is tax funded.
Okay.
But the critical thing is you must register.
Why must I register?
Let me tell you why you must register for you to enjoy the 1, 2, 3 level 3 treatment free. Because
P.S.
you are a Kenyan.
I'm registered as a Kenyan citizen.
Yes.
I have an ID. Right?
Yes.
Because I have an ID and because for level 1, 2, 3, I don't need to pay anything. I just need to walk in, walk out. Why must I register?
Let me say this.
What I'm asking is, don't you think this is creating barriers to access to healthcare? That registration process, you register and then that database is kept here, and yet I am a citizen. I'm in this country. The government knows I'm here. If I put my ID, because that's the first thing that the star 147 hash asks me to do, put my ID, it already recognizes me.
In fact, we are together.
So why do I need to do that?
Why have you put your ID there, 1 star 147 hash?
I'm assuming it's because it's reading with the registry of persons.
Correct.
So so you already know me.
We know you.
Uh-huh.
Now we want to take you to the healthcare system, ecosystem. We know you. But you are saying we were pulling you from the National Registration Bureau to now take you to the healthcare ecosystem. So that what happens there on your healthcare ecosystem, it is between you and the doctor.
Okay.
So that's the reason why we're saying, yes, we do know you are Kenyan. We want you to register because we want to take you to the healthcare ecosystem where now you'll be interacting with I've said, the health workers and the facilities and the claim, all right? And also for the government to have data, records for planning, because we can't know how to plan for the Kenyan healthcare if we do not know that how many people are there at level 2, 3, how much do we need to cater for? So you can see what we're doing currently is just saying, okay, make a provision for the budget. We need to say we have this number of Kenyans there in this area. We want to support those facilities through capitation. When you visit those facilities, that's when you know that these are the number of patients that you
usually visit.
Who visit this, and therefore we capitate you based on that.
Okay. So the question here is, I think you said it, that if one has not registered, that they will not be able to access healthcare. But you have a database which exists already of folks who've been accessing healthcare for the past decade, if not more. But you're precluding them from accessing this healthcare, and you know they exist already if they have not re-registered on this new system. Am I right?
Yeah.
Yes?
Yes.
Okay.
Now let me explain
Which
to
is
you.
unfortunate,
Yes.
because you have my information, but you want me to register on a new system, which is taking time. I don't know what number you are on now, but last week the numbers were pretty dismal. But maybe you can share that with us in terms of who's registered so far and where we are. But that means that today, October 1st, if you're not registered on this new system, regardless of whether you're registered on NHIF, you will not access medical care.
Now let me say this. When we designed the law, initially we wanted to have all Kenyans register fresh. We did not tell you shall be excluded because you're in NHIF. We said, can we start with all Kenyans registering? And that's what we are doing, by the way. So we continued telling Kenyans register. However, because there were challenges with it, I said the 12 million NHIF registered members. We knew they were there. All right? So we said we have our own loyal members of NHIF. All right? And therefore, we need not to disturb them to tell them register again. So what we did is we sent them messages thanking them for being loyal members of NHIF, and informing them that come 1st of October, you will receive your health care through Social Health Authority, because that's now the new authority that is delivering healthcare for those members who are NHIF. So what we did is we cleaned up that data of NHIF. What did we do in terms of cleaning? Because our single source of truth is the NRB data. So we compared it with NRB data. And guess what we got? Out of the 12 million, we got 9 million, meaning there were 3 million that were not known. If you compare them with the NRB data.
How is that possible?
It is possible.
Wait.
It's magic.
There were 12 million registered members to NHIF.
Yes.
That means they've contributed at one point or another, right?
Yes.
Whether they were regular contributors or not is a different conversation. But at some point, they became members because they contributed. At some point.
Yes.
Right?
Now.
And that's how they got into the NHIF database. As they were registering for the NHIF database, were they not using their IDs?
They were using.
So they are in the National Registration Bureau already.
We also thought so.
So what happened?
When we compared with the National Registration Bureau, it gave us a figure of 9 million. And when you are comparing with the National Registration Bureau, it has to match the data there.
So those are alive.
All right? Get me well.
Okay.
This is the reference.
Yeah.
This is the reference. National Registration Bureau.
That has all the IDs.
That has all the IDs.
Yes.
Single source of truth.
Yes.
All right? Now, when you compare this data and what we're saying, the single source of truth, out of the 12 million, we got 9 million.
Okay.
We have said it is okay. And we made a provision within our regulations to now migrate
The
9
9
million to as registered members. And we are notifying them that now you have been, your data has been transferred, or your movement has gone to NHIF because you are already a member. So that, for us, is okay. We are then, now the key thing that is going to follow is when they go to hospitals, they will be required to do the biometrics anytime you visit. Just like any other normal insurance, whether private, you have to use your biometrics. So that data is there, but now when you go to hospital, your biometrics will be taken, confirm this is you, and then you'll receive your treatment. So we have not discriminated or told them that, okay, you have to register fresh. We took note of that and said, for NHIF original members, they already, we have their database, we have their records. What we simply did is compare it with the NRB, which everybody is doing now, because when you're registering, the first thing is put your ID. To hit your NRB records to confirm you're the ones, then okay, you're registered. So we did that for the already existing NHIF.
So to put it in plain English, what you're saying is existing and active NHIF members are already being migrated to the Social Health Authority.
Yes.
And they are only receiving a notification telling them, we have migrated you. And they do not need to register afresh.
Yes.
I didn't receive that SMS, by the way.
You are going to receive. We have 9 million of you, so.
Okay.
I already went to 147 hash. So what's going to happen when now this message comes?
No, yeah, okay. You just a communication. A communication is just for you to be aware that you are already in NHIF.
But the point is, if you are an active NHIF member, as of 30th of September,
yes,
you are an active SHA member.
Correct.
As of 1st of October.
Correct.
That's the message.
That is the message.
Star 147 hash. Our guest is PS Harry Kimtai.
So, PS, I have to ask, when we get down to the nitty-gritty of this, because we've understood the digitalization,
yes,
and we've understood that we're going from, treatment towards now, preventive as well as promotive care. That is all understood. And then looking at this, the mechanics around how this will work. But then when we get to the nitty-gritty of it, the question that Kenyans are asking today, okay, well, I mean, it's partially answered because you were clear that if you've not registered on SHA, with SHA, you will not be able to access medical care. You've also talked about the fact that, okay, from the numbers that you get from NRB, we're looking at 9 million people who have been, what you say, members of NHIF and are going to move on. But there are many more who would essentially get onto this new system. I would imagine that today, yesterday, last week, that the system is inundated with requests to then be able to get on. And at some point yesterday, we know that even getting onto the system has been hard. I'm going to just list a number of issues already that are being faced. There are people who are above the age of 70, who, when they're trying to log onto the system, are asked certain questions and they cannot be found. So then they're asked to wait a couple of days before something else can happen for them. There are people who have tried to access the code and are not able to. One would understand that traffic is high and that everybody's trying to get on at the same time. How can we be assured that people who've been trying to register within their rights, paid up members, for example, are trying to register, can actually get in with the mechanic issues that you're obviously having right now in terms of getting everybody on board? How then does that affect the treatment or the medical care that we can offer to Kenyans if they've not been able to get onto the system, which you demand them to be on in order to treat them?
We are saying that the 9 million members are already registered. That means you walk in, you will have your records there, you will be treated. You will not go through the rigorous of, again, registering. All right? We have the other 2 million now, more, who have registered on their own. Are fresh.
Okay.
Those ones, they go in there, they don't have a problem. We are saying today, now, because of fast, we've said we are going to use digital system. When you go there, we have what's called if you had challenges, for example, the 70-year-old, we have the community health promoters whom we know that they visit the households. They are out there helping those to register what's called assisted registration. We shall station them also within our facilities so that when they come, they are helped, they are assisted, they're registered. And they're put in the system immediately. So for those who are in level 2, level 3, they will continue getting their treatment and go back home. For those now who will be in level 4, level 5, and 6 even, he will then have to show or prove the system in itself will just get to know that you are a fully paid up member. If you are not, then you will have to pay for your membership, for your social health insurance, all right? Which is SHIF now. Please differentiate.
Okay.
And
because
this is for
now,
level 4?
Level 4, level 5, level 6.
Okay.
Because now you walk into that facility where it demands that you have to have paid your insurance.
Okay.
So when you walk into the facility, what you're paying for is your membership and not your treatment.
Is your premiums. You use the word premium.
Okay, you're paying your premiums. Oh, I like to look at things in a practical manner so that they can be understood.
All right.
Okay. Ndu walks into level 4 facility in Nairobi. Mamaruse. Today on Kangundo Road.
Yes.
Today.
Yeah.
Right? I am obviously not there for a headache, fever. I am there for something else. It has already been established that what is 456? What are we doing? What are we treating here?
I don't know.
It's not a headache. It's not stitches.
You've been referred from a dispensary.
I've been referred from a dispensary.
Where you require now maybe to go for further scans.
Yes. Okay. So I need to come and get an MRI.
Yes.
And I go to a level 456 today.
Yes.
I walk into this level 456 and they tell me, sorry, Dada, you are not on the system. But I need that thing because I am sick and I cannot go back. They've told me, you go get this cancer, we can find out what's happening, we can treat you. What you're saying, Bona PS, is that the premiums, if I pay my premiums, depending on where I am, I will be treated that day in that hospital? Or are you saying that I pay my premiums and on that day as well, I pay for my scan and whatever treatment that they need to give me before it is now
getting
updated
processed?
As I'm getting processed. Which one?
You pay and you get your treatment because you are paying to your premiums.
So am I paying my premiums or am I paying
premiums.
for my treatment?
You are paying for your premiums, which enables you or entitles you to benefit from that service.
Okay.
So basically what you're saying is as soon as you register, then you are immediately eligible for all services.
That is the thing. That's eligibility criteria. The only eligibility criteria for...
As soon as you register.
Yes.
And you need to pay just the first premium.
Yes.
If I went to the hospital today and I paid the first premium, which is the first month,
yes,
that's it. I get the service.
you get the service.
Then I continue paying per month, etc., and
Yeah.
I'm okay.
Yes.
Okay. Now, is that the situation today, October 1st, around the country?
We have assured Kenyans that if you have registered and you go to the hospital and you are paid up member for level 4, 5, 6, and you visited the facility, even if you have not paid earlier, but you reach the facility, you realize you had not paid, pay that amount, the premiums that you are supposed to pay, and you will receive service immediately.
Okay.
Okay.
Level 2, 3, register and you will receive also treatment and you go back.
Okay. Do the people who are operating this system sitting in these medical facilities have this information? Are they aware that that is what is supposed to happen?
We are still communicating. Of course, this is a new thing. We are communicating. The way of doing business is different. It's people are learning new things. So we are communicating to them. We are telling them, look, this is how you need now to treat patients. And that we are saying, what's going to happen? What's going to change? Is the way we now look at the patients who are paid up members. So you should not say, you paid yesterday, so wait for, before you do
3 months.
you have to wait for 60 days.
Yes.
All right? So that is now a thing of the past. But it's communication. I do agree with you.
Okay.
It's going to be communication gradually.
Yeah, because people are
Even
already
if you-
being turned back, eh?
And that's the problem.
People are being
PS.
turned back already and being told that if you don't come with cash, we cannot treat you.
At that moment, PS,
Yes.
somebody has gone to hospital. They are unwell.
Yeah.
They are vulnerable. They need that service. You know, it's not something that you can postpone, right? Or some people have already been getting a service. For example, DJ Kroba is a known personality in this country. He posted on X yesterday. I'm going to just share. This SHA thing just threw a huge curveball on all dialysis patients countrywide. My wife just got a call from her dialysis center where it's paid via NHIF, and she was told to pay cash together with thousands others. One dialysis session is 9,500, and my wife does 2 sessions a week.
Well,
So she's already being told, now NHIF tumemaliza nayo, now when you're coming tomorrow, ebu come with cash because we don't know this SHA story.
now, let me tell you, Latiff, we have people who are anti-change, anti-reforms. They send messages. We know that they have been telling people, now forget about, we don't know, you will be on your own, come fast, because yes, we know you have been a member of NHIF, you will be on your own. I can to tell you that we have also gone further. And we asked the SHA staff that send messages to all the renal patients, and they shall not be returned. And we shall still continue, as I'm telling the nation now. And I believe the medical practitioners, the facility health providers are listening. And if they're listening, they should not turn away those patients. We've said, even if they have not paid and they have the money, that 9,000 that they're supposed to pay, that should go into paying for their premiums. And they continue receiving their dialysis as normal. That is the message that we are passing to the Kenyans, we are passing to the healthcare providers, that they should not turn away patients because they believe that we have shifted from NHIF to SHA.
Okay.
And if there is any challenge, we have our call centers, they need to ask, and we shall provide the directions. So it's not just a question of turning away the patients. You turn away the patients, is it because of lack of information?
Probably.
Right.
Let's just look at it from that point, all right? That this healthcare provider is actually honestly just wondering, so who is going to pay for this service?
Yeah.
Because up to where they are right now, they don't know, they don't have the system with them, they don't know how they're going to treat this patient that they have actually received. How are they going to claim this? Because like you're saying, it's still communication that's going on. There are some centers that are offering these critical care services that don't know. if we continue, we offer this dialysis service to this one person today, this dialysis session, how are we going to claim it? And we're not going to be called fraudsters.
Okay, they say that come with your 9,000.
Yes.
They say so, isn't it?
Yes. Come with
Meaning
9,500
they expect
cash.
them to pay cash.
Yes.
Yes.
We are saying register and pay your 9,000 that you are going to receive the treatment, and that will become part of your premium. So what we want is not to pay cash separate. We want that to go into your insurance premiums.
Okay. Sorry.
Here's the problem.
Yeah.
Sorry, Ndu.
No, go ahead.
If I go to this dialysis center, right, and I pay 9,500 to SHIF, I am not paying the center,
Yes.
right? But the center is the one that's offering the services.
But the center will claim.
And the center doesn't know now how I'm going to deal with these claims, because at this point, their challenge is they don't know the integration, the migration process. They know the system that they've been operating on with NHIF. This is how we treat, and this is how we make our claim. They don't know how they'll be doing the claims for SHA and SHIF. So at this particular point, this patient needs dialysis. She needs 2 dialysis a week.
Yes.
She can't miss one.
So the fear is the facility.
Yes, the information.
The facility. We have all those facilities that were registered or accredited with to NHIF. We've communicated to them. They have the message, they have the information, because they were contracted with NHIF. They still have contractual obligations. We've sent them also new forms now to be to contract. We want to contract their services under SHA. So we've given them all the details, how to register. And so I can tell you, Latiff, we have over 7,000 private facilities which have registered with the SHA. They have already been notified, because this time it is different. Before, if a facility is new, we have, you go to the KMBDC, you apply, you are registered. You go to NHIF, that was before.
Yeah.
You now apply. The NHIF staff tell you, okay, we shall come on Tuesday, we'll come and
visit your
inspect,
facility.
we shall visit your facility, all those things. We say that is burdening. It's making the business cumbersome, because that's processes, bureaucracies that we are developing. In this new act, we said the only competent authority to license a facility, healthcare facility, is the KMBDC, which is the council that's supposed to register. And we informed KMBDC that all those facilities that you have registered and within your database, please migrate them and link with the Social Health Authority database. So that happened. They are aware, because we want them to lodge their claims to SHA. We also told them that now, effective this date, you will be lodging the claims, all right, to SHA and not NHIF. Continue providing service,
Okay.
and lodge your claims to SHA.
I want to stick on this 9,000 shillings for dialysis, for example.
All right.
Right? And so, because what you're saying is that, let's say I was going to hospital under the assumption that I'm going to get my dialysis done that day. I don't have the 9,000 shillings, but I have the what? What is it that's the premium for somebody who's...
Let's say 300.
300
is the lowest.
Is the
right?
lowest amount of the premium. What you're saying, PS, is that if I go to that facility and I pay 300 shillings, it's going to go towards my premium, and that facility should actually put me on my dialysis session for that day.
That is the practical way we are doing.
That is what is going to happen.
Yes.
When will all of these facilities get this information about what is supposed to happen? Because the reality on the ground is that they will, PS, today. They will turn people away who've come to get treatment, and they think that they can pay just a month's premium or one-time premium and get treatment. That they will turn them away because either one, they're not aware of what you're saying, or number two, they're worried that they will not get the money for delivering the service of dialysis or whatever treatment that is supposed to be offered. So how long or how far reaching will that information be because we're stuck on the people who are going to get treatment and what will happen to them.
The beauty of it is that we have the database of those who are registered with us, with the SHA now. We have their database, we have their conduct, and I think they have been notified. But as I said, we shall continue communicating with them, telling them what to do. Because anybody with a new system, new way of doing things will always keep on asking, how do I go about this?
Of course.
It is natural.
Of course.
So what we need to do is continue communicating until they get used to it. They'll say, this one, it's always like this.
Yeah. Or even before I get to the facility.
Yeah.
Even before I get to the facility,
Yeah.
because these things are online now. I can be in the vehicle, matatu, whatever, in my car, and I pay my 500 bob.
Before I get there.
Before I get to the facility. And I can show the people I've come for dialysis and I've paid my SHA premium. I've paid so I can actually get my dialysis tomorrow, October 2nd, when I appear at the facility.
That's what you have said, that we want Kenyans. You see, the thing here is service. We want Kenyans to receive service under this new program of reimbursement to the facilities.
Yeah.
That is the word. So we do not want you, unless you're saying this, you're paying it out of pocket.
Yeah.
That is different. But as long as you want to pay to benefit under this insurance fund, then you pay your premiums. We are saying build up, pay for your premiums.
Yeah.
As long as you know you have been told to pay, your premium is 6,000.
Yeah.
So if you've paid 3,000, 2,000, that's building up to your premiums. The most important thing is pay your premiums.
How do I know my premium?
Yeah.
How do I know my premium?
You know your premiums through, if you are employed, we have no problem because your employer
2.75%
of your
of my gross. If I'm unemployed,
If you're unemployed, we have the proxy means testing that will be subjected to. That what you are saying, that the questions that they are told, the many questions, because we want them to go through proxy means testing, a procedure or tool that will be able to help us do an assessment of your income and determine your 2.75%.
Yeah.
And therefore, that is the premium that you will pay.
I know you can't collect water that's been thrown on a stone, but this awareness and awareness creation and building and information, would it have been possible to do it months in advance to kind of let people start to know over time, this is what is going to happen, this is how it's going to roll out? Would that have been possible?
You see, I think Kenyans also have a way of doing things, and we must understand that. Since last year, the president declared that we are now moving to universal healthcare coverage. We launched it on a national day. We informed Kenyans. What then required us is to come up with the procedures, which we call the regulations. We did that. We went round with the regulations. We informed Kenyans, this is how we are going to do business. All right? All that was done. Now here we are. As we told people, start registering as early as July. Register. That time, people triggering when you go to the registration portal, 2 people, 3 people. Now it started building up. It started building up as we were moving towards the D-Day, which is today. As of yesterday, the number of queues that we had, because when you're interacting with the service providers, like 400,000 people on the queue. If you just talked about traffic here, all right, everybody getting out on the road at the same time, definitely you have a build-up of traffic. It happens. It happens.
Okay. Yes. Please come back again. Please. Because we now need to create more and more awareness. And thank you for joining us. I've registered via 147. It has told me to go to Afya Yangu. It has told me my credentials are wrong. Well, we'll deal with that. PS Harry Kimtai, the PS for Medical Services, has been our guest. We have migrated to SHA. Now you should be getting other services. No, medical services. If you have registered to SHA, go to level 1, 2, 3, free. Go to 4, 5, 6, you pay through SHA. Go to emergency care, shift,
yeah,
and all. Come again.
This is the Situation Room, the only way to start your day.